Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
That was our first attempt to go after the music, so maybe a bit of room for improvement, certainly on my side. Anyway, so today we're going to be talking about DREAMSeq, which is sequencing of systemic therapy in BRAF mutant metastatic melanoma. But before that, icebreaker warm-up question, Sapna. So what's your favourite place in the US? That's an easy one.
Oh, yeah. Depends on what I'm, is it my favorite place for having a great time and hanging out with friends or for myself? The place I like to go for solitude and quiet to reconnect is a place called Santa Fe, New Mexico. And now that I'm in Colorado, I'm even closer to it. It's just a beautiful, quiet town filled with art and Southwestern flair. And it feels like a place where I can clear my head and go for long walks or jogs in the mountains. They do a lot of these kind of Japanese day spa, massage, facials, beautiful things up there. And then just a beautiful art district. They have a street called, oh my gosh, I'm blanking on the street, the beautiful street that just has a bunch of beautiful art galleries and food and things. So yeah, that's the place I like to go to quiet down.
Yeah, we can put the exact name of the street in afterwards on a fact check or something like that. Show notes, whatever it's called. Sure. And then another time I can ask you about your favorite place for kind of having fun, as it were. But anyway, so let's talk about DREAMSeq. And maybe before I ask you to talk about the trial, maybe the history is relevant here. And I suppose what I'm thinking of is that going back 15 years, in terms of approvals at least, we probably just had ipi mono, really, in terms of the kind of current treatments. And then we had vemurafenib before we had any other BRAF targeted therapy. So we really just had these two options, actually, for quite a while in clinic. It felt like a couple of 3 years anyway. And so in patients with BRAF mutant metastatic melanoma, we had these two drugs that we could use to treat them with. And I have to say, my experience, first of all, I tended to treat people with vemurafenib, and then when they progressed, treated them with ipi. And I found out very quickly in clinic that actually ipi monotherapy really didn't work well in people with bad disease. And so it didn't take me long in terms of clinical practice to think, hang on, even if it's BRAF mutant melanoma, let's go with the immunotherapy first and then use the vemurafenib afterwards if it doesn't work. So that was kind of my clinical experience.
Did your kidney cancer experience play into that? Because there was a bit of TKI after IL-2, TKI before IL-2, and there seemed originally to feel like there was a sequence. If you were going to use IL-2 or immunotherapy, granted it's IL-2, that would come before a TKI, but then access to TKIs was big. Anyway, did any of your kidney experience play into that, or?
I don't know. That's an excellent question, actually. I hadn't really thought about that before, but we weren't using much insulin in the UK anyway. It just wasn't really a thing in the way it was, at least in some places in the US back in the day, as it was. So that's one comment. But we were using a little bit of interferon. I'm not sure, though, at the time, we kind of had the data to say that that's the way you should do it. But I mean, the way I kind of thought about it, putting the clinical experience to one side, is that if you've got a potentially curative treatment, and I think we can say that probably about high dose interleukin-2, in selected patients, probably for renal and melanoma, then you should do it first. And if you're going to be using a targeted therapy, and the VEGF, tyrosine kinase inhibitors, they have cardiac tox and all this stuff. They are not drugs you want to be using before you gave interleukin, high dose interleukin-2. So I don't know, but yeah, maybe you're right. Maybe that was a factor. Anyway, so I guess that's some of my experience historically in that kind of my historical context. But yeah, tell us about DREAMSeq and why did it take so long to do DREAMSeq?
So First of all, this was a trial, conceptualized through the U.S. cooperative groups, but many academics, I think, had this idea. This was at a point where we now had combination immunotherapy, nivolumab, ipilimumab, based on your CheckMate 067 study, and combination targeted therapy, dabrafenib, trametinib, based on COMBI-D, and COMBI-V, as it were. And maybe cobimetinib had already been on the market here, but at this point, I think dabrafenib and trametinib, because they were really the first combination BRAF MEK available and approved, was the combo du jour. This was pre-encorafenib binimetinib. This was nivolumab, relatlimab. But these drugs were now approved, and it was exactly as you say. You have a BRAF positive patient in clinic, and there was this question, we have to sort of choose either combination immuno or combination targeted. And there's logistical issues. There's real world issues as far as which one can you get into a patient faster. In the US, sometimes these oral drugs were needing these authorizations that were taking quite a long time. But by the same token, maybe infusions could be faster or not, depending on saturation of your infusion unit. So there are all these other real world things at play. There was a feeling of what might change in the tumor microenvironment if you were exposed to one class of drugs first versus another. And ultimately, we needed to do a sequencing trial. And so Mike Atkins developed this trial that basically says, we'll just take BRAF positive patients in the metastatic frontline setting and randomize them 1-to-1 to combination immuno, and at progression, they will get targeted therapy combination, and the other group will be the opposite. They'll get randomized to targeted therapy combination, and at progression, combination immunotherapy. And then, what we had known at that point, if you had ever looked at a curve of immunotherapy, Ipi-Nivo even really, what we knew is there's always an early drop-off. Immunotherapy takes a moment to engender, an immune response, immune cell trafficking, activation, all things. So there are patients who progress in that moment while their immune system is trying to get shored up. On the other hand, with targeted therapy, majority of patients do well from the beginning, and it's later that they end up hitting kind of their median progression, and the cure fraction falls off. So the shape of those curves look differently. So Mike was actually very careful when he developed the statistics to this. He went for a primary endpoint of 2-year overall survival. So he went for a landmark endpoint. Landmark endpoints will take longer to enroll. You need enroll more patients to make sure you cross that landmark, as opposed to a median. You could have done median OS, you could have done a median PFS. The problem with medians is that, median is going to tell you about basically at any point, what is the delta or the difference between these two groups of treatment? And when you have curves that the shapes will look different, they won't go in parallel. Are they non-proportional? I don't know. That's an argument for statisticians, but they will cross, I guess is what I'm getting to. Invariably, they will cross. You've got the immunotherapies that might drop off quickly and then flatten at a hopefully higher rate. The targeted therapy that will stay good for a while and then drop off. And so there is some presumptive crossing. And when you pick out a median, your confidence interval is going to cross 1 at that point. And you will have essentially a wide confidence interval for one being better than another. It will be hard to find a statistical p-value. But a landmark, if you say at this point in time, the curve should have crossed and we think things will start to show. And that was some of the modeling done. At least that's my understanding of why they picked this 2-year overall survival landmark. It's one of our few trials that have that type of an endpoint. And, the bottom line is, in the group that got immunotherapy first, they had an exactly 20% improvement in overall survival at 2 years compared to the group that started with immunotherapy first. The response to immunotherapy after targeted therapy was lower than the response to upfront immunotherapy, while the response to targeted therapy was fairly maintained, whether you got it in the first or second line. That has real world implications. Because this was done on a trial, they had to control for certain things. So you controlled for sometimes brain mets eligibility, then you didn't. Then you controlled for things like the dose of Ipi-Nivo. Then to make it broader, they allowed inversion of the Ipi-Nivo dosing in case people wanted to use that. At the end of the day, Mike will tell you there were very few people who got that inverted dose of Ipi-Nivo on this trial. But one of the key things is once you progressed on one of those arms, you needed a confirmatory scan, so often 4 weeks later. But in the US, if that's tough to get, that might be pushed to 8 weeks to get that confirmatory scan. Once you were confirmed a progressor, then you switched. And as a result, progressors on the immunotherapy upfront arm, essentially those early progressors that progressed within the first 6 weeks on treatment, I believe, none of them touched targeted therapy, which is really just a pity. And in the real world, we would never let that happen. If we thought somebody was clinically progressing or invisible, we would move them over to BRAF targeted therapy without a washout. But this was a clinical trial, and you're trying to be careful of overlapping toxicity. So there was this, confirmatory scan and or even a washout period that then caused these patients to be so delayed in the initiation of that second line targeted therapy that they didn't touch it. So there's some clinical trial artifact that's built into the way those curves end up looking.
Yeah,
but that's really DREAMSeq.
Well, there's loads to talk about there. I mean, the first thing, that whole, the curve, if you see what I mean, where you've got the kind of immunotherapy and then, trying to get the best of both worlds. I don't know, who first sort of talks about that in public, but I remember Tony Rebus talking about this really clearly at a meeting or something else. So I call that the Rebogram. That kind of idea, that putting these to get the best out of it for patients. And actually, while we're on the subject of grams, the graph people always show, which shows the toxicity kinetics for Ipi-Nivo. Well, Ipi originally, I call that the Webergram, because I think that paper in JCO from Jeff Weber, I think it was about Ipi. Tox kinetics, first of all. That's just a bit of fun. So listen, lots of questions, lots of things to talk about, but could it have been single agent anti-PD-1 as well as Ipi-Nivo? I know it wasn't, but why not? Is that, would that have been reasonable? Many patients at the time in the US getting single agent anti-PD-1. And I just put to one side the whole issue about Ipi and BRAF mutant melanoma, if you can.
Yeah,
because retrospectively one can say that, but at the time, was there a strong feeling in BRAF mutant melanoma that you should be using Ipi-Nivo?
Yeah, that's a good question. I was just checking myself. What was the enrollment date? So it was activated on July 13th, 2015. By the way, we're reading this JCO publication here. So in 2015, I think, we were already pretty happy with Checkmate 067 and just the strong efficacy that we were seeing there, regardless of BRAF status. We wanted to give combination, so I think it could have been PD-1. I don't know. You asked me a question about enrollment. I mean, enrollment took forever on this trial because we were using standard agents. And the question is, why do you need to put somebody on a trial when you can just pull these off the shelf and try one sequence or the other, or you already have your inborn bias about which one to start with? If we had done it with PD-1, I don't know if the trial would have ever finished accruing, because people would have had their bias about combination at that point. Having said that, I think you and I both know there's a real world sort of database going around of PD-1-seq was the name of the trial, right? It's the or name of the collection, which is who got PD-1 for BRAF positive melanoma versus BRAF MEK, and then the switch. So we might see what that actually looks like in some short time.
Yeah, no, I wasn't sort of thinking it should be or should have been anti-PD-1 monotherapy. More like this could be an option. So you just say, actually, it could be Ipi-Nivo, it could be anti-PD-1 monotherapy. Yeah, and I guess it's a footnote now. So then, getting back to the patients who progressed on Ipi-Nivo didn't get targeted therapy. I mean, people have talked about that a lot, and that curve gets shown a lot as well about those early deaths, basically. So obviously that's a great shame, and I don't think there's much more to say about it, other than I would say that means that the benefit in that strategy or that arm is actually underestimated, because actually if those patients who died had got targeted therapy, I suspect some of them, I mean, we know it's a bad group of patients, right? And so maybe they wouldn't have got out to 2 years. Maybe they would, maybe they wouldn't. But those curves would definitely look different if those patients had gone on to. And I think some of them actually may have got out to 2 years. So I think that's an important point. So, was it a practice changing study or practice confirming? To get back to my kind of original comments.
there was no label change that anybody was going after here. It was really just for us practitioners to know how to use it. So probably it was practice confirming. The reason it was struggling to enroll is there was already a feeling at some point that immunotherapy first, based on, just you were saying, there would be anecdotal experience of people using it. Asierto had been looking at sequencing, back in the vemurafenib IPI days, sequencing, combining all the iterations of it. And there was already a feeling that while targeted therapy first could, be accessible for many patients, that what it does to changing the tumor microenvironment may actually lead to less benefit from immunotherapy. And so people were starting with combination first. I think the study confirmed it, but it also has to have shown us there is a group of patients for whom targeted therapy needs to be started first. And not just that they get their immunotherapy, they do poorly, and then we get them in the real world quickly onto targeted therapy, but maybe you actually start with the targeted therapy first. And when you look at the characteristics of those patients, it's the patients who are the toughest to treat. It's high LDH, it's visceral crisis, multiple organs involved, presumably some of diameters of their target lesions is quite large. And so there is, and my addition to that is if they have brain mets, if they have active brain mets, even if they're asymptomatic, there's a part of me that kind of wants to start with targeted therapy because the capacity for them to go badly with immunotherapy taking too long, unfortunately, is sometimes too high a risk. And I would rather debulk them. Now, there is that early work from Jen Wargo and Arlene Sharp that says, though, when you start with targeted therapy, there's a way to optimize the window in which you give it. And this will certainly help us lead into that next paper that we want to talk about next podcast. But, giving targeted therapy to progression is certainly one strategy. But you have so significantly altered that tumor microenvironment and the immune bubble. BRAF oncogene itself is an immune suppressant. So you break that force field, you allow the T cells in. But after those T cells have educated, too much targeted therapy gets those T cells out of there. You start getting a different batch of T cells, or you get no T cells in your tumor. And so then coming in with checkpoint at the time of disease progression, those T cells have long gone. And you don't have this good interaction between the checkpoint inhibitor on the T cell and the tumor and the drug that you're giving. So there's an optimized window, and it looks to be somewhere in that 1 to 4 week range. The issue is when they did that study, the biomarker study, they couldn't bring a patient in every day and biopsy that tumor every day. It was also hard to do that every week, but they found at 2 weeks, they had an influx of T cells on somebody on BRAF targeted therapy. But by 4 weeks of targeted therapy, those T cells were gone. So there's some optimal window. Get those T cells in, take the BRAF MEK away, and give, the immunotherapy, or, in some fashion, you could imagine combining it. That's not what DREAMSeq did. DREAMSeq was a real world, reasonable regimen of you've got to treat to progression and then at progression switch. I think many of us have taken away that those early progressors, it would be really interesting to give them a fixed dose of BRAF MEK, not wait till progression, switch them, and then at progression on their immunotherapy, switch them back to BRAF MEK. That's a luxury we have in the States, probably not one that is as easy to do in other countries, right? To touch a BRAF MEK and then come back to it later.
Yeah, no, there's lots of good stuff in there and lots of interesting points. I mean, I slightly wondered to myself as well about the issue of variability from patient to patient in terms of the kind of quote unquote optimum window. I mean, I hear what you're saying, but I slightly wonder whether it might vary from patient to patient. And the other point I was going to make was, and then that would come into, is there a way to individualize this with, some of the marker scanning or, ctDNA or whatever your favorite thing is. But what I was going to say, excuse me, is the other thing, if you treat to progression, we all know that in those bad patients, the kinetics of the disease then are like this. And so you've actually got someone who's progressing rapidly. They might be immunosuppressed and sick as a consequence of that. And that's not the place where you want to be giving your immunotherapy checkpoint inhibitor treatment. I'm going to cough again. So next question, maybe my final question. I'm just reading the conclusion, which is one line from the JCO paper. Combination Nivo-Ipi followed by BRAF and MEK inhibitor therapy, if necessary, should be the preferred treatment sequence for a large majority of patients. I think that's an uncontroversial statement. But two questions for you. One is, does it matter what the BRAF MEK combo is? Because they don't specify in that concluding statement DAB-TRAM, suggesting that other ones would also be okay. So do you think that matters? And then the other bit, it says Ipi-Nivo, and again, kind of discussed this already, the BRAF story with Ipi, but what if it was Nivo-Rela? I mean, what do you think about that? Would that still be okay instead of Ipi-Nivo, or would it be less good? Do you think it's generalizable for other checkpoint inhibitors?
You just pulled a Jeff Sussman, you realized, which is, I've got two questions for three different speakers.
I'll take that as a compliment. That's a compliment, right?
It is a compliment. You're asking multiple questions. So your first question, does BRAF MEK matter? I guess the short answer would be no. If people have a preference for Oncobeni, there is a study called the EBEN study that did something like this, but more of a fixed dose as well. Anyway, there is some feeling, I think, that people will try to assume that Oncobeni is best in class for BRAF MEK inhibition based on median PFS and some duration benefits. But as we all know, there's also toxicity to be considered and things. It is tolerable, but it's a high pill count. It doesn't have a food effect. You don't have to be fasting for the MEK or refrigerate. There's things. So I don't think the BRAF MEK matters. I think just the fact that we know in all of those trials, you hit the target quite effectively, and 95% get disease control rapidly. So the choice of BRAF MEK, no. The choice of immunotherapy combination, yes, I think it would matter. So I think if you did a RELA DREAMSeq, so a relativity DREAMSeq, where you said that we're testing the sequence of BRAF MEK versus, compared to Nivo-Rela, in the BRAF mutated population, the BRAF positive population, the exploratory work from Checkmate 067 certainly shows a benefit in combination. Also in that Immuned study, combination in the BRAF positive population, boy, that curve is riding so high compared to placebo or single agent. So we know immunotherapy works really well here, but we know that for Nivo-Ipi, in relativity, we should really, I need to familiarize myself on how well that does in the BRAF subgroup. But my takeaway is that it's Nivo-Ipi that's really the predominant. And then for many, many other sort of metrics, Nivo-Ipi is outstanding, for OS, for the PFS it gives, for the treatment-free interval, for the duration of benefit, that I'm not so sure Nivo-Rela stands up in the same fashion against a BRAF MEK. So I would caution that this means, as the authors concluded, and I agree, it's non-controversial. It's right.
Yeah, and I guess for the record, and you said this already, but maybe it's worth saying again, we're talking about quote unquote full dose Ipi here, basically.
Full dose
and the
Ipi,
patients that went into this trial. Because, I mean, when you're talking about late landmark endpoints, that's always something that I think about when we're having those kinds of discussions. Okay, go on.
One thing I would like to see, and I'm sure Mike will show us in years to come, and I'm hoping it wasn't in the supplementary that I just missed here, but one thing I would like to see is the incidence of brain mets in these two regimens, over time, starting with one or the other. And we can talk about that when we talk about Secombit, because we've already seen some of that with that data, which is intriguing. So.
Yeah, I think actually we're going to be talking about brain mets quite a lot, not just now, but in the future as well, because it just feels a little bit to me that on some of these later time points from some of these pivotal trials, we might be getting a few surprises actually with brain mets, unfortunately. That's my kind of gut feeling. And it's obviously always been a massively important subject in melanoma. Okay, so DREAMSeq.
Yeah, I'm just fussing around with the music, trying to see if I can get our outgoing music teed up.
I was going to say, I don't know if we're still recording, but and anything else we need to say about DREAMSeq? Anything we haven't covered?
Yeah, no added talks. This is that we didn't see that there was really any overlapping. It probably behooves us to mention And in the fact check, if that's utterly just incorrect, we'll fix that. But, sequencing these regimens is reasonable. Start with immunotherapy for most patients, with the caveat that that may not be what we do in the, adjuvant space. We may not start with immunotherapy. We don't have it. We can't, move in the adjuvant setting from one to the other. But this at least holds true for first-line metastatic disease.
Okay, thank you very much.
Yeah. Let's see if we can go out with a bang here. Hi, everybody. We're doing a fact check now for DREAMSeq, the DREAMSeq article, Mike Atkins, JCO. I had it in front of me. I think it's 2022. Maybe I should double check that. September 2022. Yeah. And this was an ASCO plenary during those virtual years where we didn't meet in person. So it was one of those online plenaries. We had fact checks starting as early as our icebreaker in this episode, where, James, you asked me where my favorite place in the US was. And I said Santa Fe, New Mexico. And there's this really artsy street, and I couldn't remember the name of it, but it's a wonderful street. There's tons of galleries on it. And then a great restaurant named Geronimo, very iconic Santa Fe restaurant. It's Canyon Road. Canyon Road is the name of the road in Santa Fe, New Mexico. And then we had also, I noticed we didn't actually say the ECOG Akron study name in this episode, which is important because this was a cooperative group study, not sponsored by industry. And so it's EA 6134, but because these numbers are a little cold, and I think I had told you earlier, James, that we name our studies, the nomenclature has to do with kind of the year it was developed and where it was in the SWOG portfolio. I'm not sure how ECOG Akron names theirs. 6134, doesn't mean anything significant to me, but I know they have some nomenclature there as well. But I remember very clearly on a call, I remember being at a uveal melanoma meeting in Lisbon, sitting on a rooftop, probably having an adult beverage and some patatas bravas or something, because it was later in the day and it was earlier in the day in the US. And I was listening in on an ECOG Akron call, and it was one of the men of ECOG Akron, maybe Ahmad Tarhini or Igor Pusanov, who said, Mike, I think you should call this DREAMSeq. It's the dream sequence. We don't know which way. And that was really how the title DREAMSeq. So we colloquially will call it DREAMSeq, but it does have a study number, EA 6134. We talked about in 2019, the study started in 2015, and in 2019, they allowed for the flipped dose of Ipi-Nivo just to make it more liberal for enrollment, to help with the accrual. But what I couldn't find in the paper is anywhere where it tells you how much of the study population ended up being flipped dose. So I don't really have a sense of that. I couldn't see it in a table or any supplemental data. And then we were just noting that in the demographics table, the proportion of V600E and V600K was a little different in the two regimens. So in arm A, that starts with immunotherapy first, it was 12% V600K. And in arm B, targeted therapy first, it's 25% V600K. And that's just interesting in light of some of our recent conversations about maybe CombiAD and some other things. I think there were a couple other things you were fact checking too, James, right? The figures and
so I kind of slightly colloquially referred to the Webergram and the Rebogram.
Yeah.
So the Webergram, what I was talking about actually was a paper from JCO 2012. Jeff Weber's the first author. Actually, Axel Hauschild is the senior author, and it's figure 2, which is a sort of cartoon description of the time course for toxicities of single agent IPI. And it's one of those ones, Sapna, if you had $1 for every, maybe not anymore, but kind of back in the day, every time someone showed that at a meeting. So it's nice. And obviously to some extent that's been superseded now with other similar diagrams for, let's say, Ipi-Nivo and anti-PD-1 mono and so on and so forth. So that's the citation for that. I haven't been able to find, or we haven't been able to find a citation for the so-called Rebogram, and the idea of that is trying to get the best out of targeted therapy and immunotherapy together to get a higher long-term tail on the curve. So I'm going to keep looking for that, but I don't know where that first came up, and I guess maybe we've attributed it to Tony Rebus, but we probably just need to double check that, and there were some challenges searching for that on the internet as well. And then the final thing was all about this. I was talking about the fact that in the immunotherapy first arm, as a consequence of trial design, not everybody got to BRAF targeted therapy. So we mentioned that, people have talked about it a lot, and that's what happened. Mm-hmm. But if everybody had got to targeted therapy, that I think would have made that arm perform better still than it did, because some of those people, rather than dying relatively early on, actually would have been salvaged by the BRAF targeted therapy. So the point I was making there is that actually the benefit of the strategy overall may even potentially be greater than what was shown in the trial. And I think that wasn't clear at the time, so sorry, and I hope it's clear now.
Yeah, I now fully understand what you were saying. Looking back, I think I was a little doll-faced listening to it, but I totally get it now. What you're saying is, in the immunotherapy first arm, we lost patients who couldn't cross over. And we said we would never let that happen in the real world. We wouldn't make them confirm a scan, or we would get them on targeted therapy quickly. And so that would make the benefit of immunotherapy first strategy even better, because then they would get both drugs. Anyway, I get it now. You're right. So DREAMSeq may even, you're right, underestimate the benefit of an immunotherapy first strategy, assuming you can get your patient on a target. Perfect.
Sorry, good.
Thanks.